All right, so in this part of the hypertension drug series, we're going to talk about calcium, ACE inhibitors, angiotensin receptor blockers, and loop diuretics. So first of all, talking about calcium drugs. For the calcium drugs, remember they all end in the word dipping, and then you have systolic blood pressure and diastolic blood pressure, two kinds of them. So the systolic is going to be, so basically these drugs select, it depends on what drugs it is. You can have calcium channels on the heart, you can also have calcium channels on the arteries. So some drugs like verapamil is going to block the calcium channels in the heart. So remember, heart pumping blood, increasing heart rate or changing anything in the heart rate and stroke volume is going to affect the systolic blood pressure, versus changing anything in the on the arteries is going to affect the total peripheral resistance, which is part of the diastolic blood pressure. So you know the drug nifedipine is going to affect the diastolic blood pressure, versus the drug etiliazine is going to affect equally the diastolic and systolic, because it doesn't really have a preference for which kind of calcium channel. Now remember that my calcium channel, I drew it in this color. This is my calcium channel. The second drug is ACE inhibitors. I'm going to talk about ACE inhibitors and angiotensin receptor blockers sort of together. ACE inhibitors end in the word pril, like April, pril, and the ARBs they end in the word sartans. So angiotensin receptor, so they basically have the same effect. You decrease angiotensin's effects. Either you prevent angiotensin from being formed, or you prevent angiotensin from doing its job. So as a result, you have a decrease in systolic, diastolic. Remember that angiotensin receptors, I have put angiotensin receptor in orange right here. In orange. So this is angiotensin receptors are in the kidney, they are in the vein, they're in the arteries, they're in the adrenal cortex. This orange thing, this yellow organ is adrenal cortex or adrenal gland, which produces aldosterone. So you pretty much decrease venous return, so you decrease systolic and diastolic both. You decrease the aldosterone, so you decrease salt and water retention, like it says right here. The only big difference is that angiotensin ACE inhibitors also prevent bradykinin from being degraded. So the reason for using sartans is that you don't get the bradykinin side effects. That's the most important thing. You don't get any bradykinin side effects, such as dry cough, angioedema. Dry cough, angioedema. So I should put it right here. So bradykinin can cause okay, and then you also decrease the sympathetic system, right? Because you just don't have that vasoconstriction from the sympathetic system. Then you have the diuretics, the loop diuretics, thiazides or chlorothiazides. That's the one we use. Why? Because the thiazides decrease or orthostatic hypotension. Rest, they decrease the salt in the body, but the water effect is a little bit less. Remember, because they don't act on the thick ascending loop. You can watch my video that says thiazides. Why do thiazides produce hyponatremia? So that's kind of how it goes. You can say, and then in the next video, we're going to talk about what happens when you give these drugs not alone, but you give them in the combination. So once you know the mechanisms, we can talk about the different kinds of how they work in combination. So I hope this helps, and thank you for watching.